In 2019, drug overdose deaths in the U.S. were at an all-time high, with opioids involved in more than two-thirds of all cases. As the pandemic continues to cause social and economic upheaval, increased stress, isolation, and reduced access to support services are making a deadly situation much worse. Dr. Nancy Campbell is a professor and head of science and technology services at the Rensselaer Polytechnic Institute. She's a historian of drugs, drug policy, drug treatment, and drug science, and the author of OD, Naloxone and the Politics of Overdose. Dr. Campbell, thanks so much for taking some time today on this important topic.
Well, it's wonderful to be here. As you mentioned, it is a parallel epidemic in many ways, and it's been building for decades. And so I'm really happy to be here to speak further about it.
And so are we. Those who were vulnerable pre-pandemic are even more vulnerable now. Whether accessing opioids legally or illegal, for many, the supply chain's been disrupted like everything else. What impact does that have? And what is the evidence telling us about the increase of overdoses and overdose deaths?
So as most people know, this epidemic, the opioid epidemic, has been building since the 1990s. And in 2013, there was a real modulation in the supply chain that led to an increase of fentanyl in the U.S. opioid supply, that is the illegal supply, and not just in opioids, but also in stimulants, cocaine, and other drugs where no one was expecting an opioid like fentanyl to be. And so we have a real crisis that has resulted from both the legal and illegal supply chains. And in a sense, this is a convergent crisis that was born in part because we make that distinction. We make that distinction between legal and illegal drugs, between medicines or medications. And of course, we have high dose opioids that are very much used as essential medicines. And we also have high dose opioids that are used illegally. And we have diversion and really a kind of mesh between the illegal and legal markets. And so in a lot of ways, that's, in a sense, as we were coming into the COVID-19 pandemic, we were already in a very difficult situation because of that deadly convergence.
And what do we know about the increases? Did I read that in the first 6 months of the year, deaths were up 13%?
Yeah, so it really depends on where you look. And one of the problems of the overdose arena in general is that there's a time lag between a death and when that death is certified as an opioid overdose death. There's also not a lot, and I wrote about it a lot in the book, not a lot of sorting out when there are multiple or polydrug overdoses. Many overdoses do, unfortunately, involve opioids, but also alcohol and benzodiazepines. All of these are central nervous system depressants. And so the presence of each of them in various combinations can make it really hard to sort out. And now in the pandemic, we do have people who are overdosing alone. And there is no possibility that someone who is in an overdose situation can self-administer naloxone. And so we have a situation of social isolation, the very thing that has increased opioid use and therefore opioid overdose. And so I think that we are seeing that in many different places, in both rural and city, urban situations. We're seeing an increase in overdose deaths at the same time as we are obviously in the midst of the COVID-19 pandemic. That convergence is particularly, to me, also exacerbated by the fact that opioids are respiratory depressants. And so what you said earlier about the most vulnerable, anyone who is vulnerable to problems with breathing is much more vulnerable to opioid overdose and to COVID-19.
It really is a double-edged sword. As an expert in the history of science, technology, and medicine relating to drug policy and the social significance of drugs, How did we get here? Where and when did this crisis begin?
Well, it depends on how long you have to sit with me. I could start easily in the 19th century when the United States was a voracious consumer of an opioid, morphine, which was synthesized in the early 19th century and which was rampantly available in the United States during the late 19th century in all kinds of patent medicines or proprietary medicines, but also through the ethical pharmaceutical market. And that's what it was called in the 19th century. Now, I would say that our current crisis, the roots of our current crisis they really lie in a very interesting way in our attempt to regulate differently. The Controlled Substances Act of 1970 put morphine, heroin, all opioids really into schedules. These are Schedule I drugs, and so they are restricted. They are policed by the Drug Enforcement Administration. And we have a war on drugs. And in a lot of ways, the war on drugs did us no favors. It really created the conditions for mass incarceration and for the racialization that we see today. But it also, interestingly, made patients, chronic pain patients, and people who needed more opioids for medical purposes, it gave them a sense of security that they didn't have to worry about overdose. I think it's a very interesting, naloxone should also be prescribed to chronic pain patients, really to anyone who used high dose opioids, and that really did not happen because although naloxone's a really old drug, it's a 50-year-old drug. It's about to 60-year-old drug. It's about to celebrate its 50th anniversary of FDA approval in 1971, and yet we haven't heard much about it, have we? Until the 21st century, really the very late 20th century. A bunch of harm reduction activists began to think, hey, why don't we make sure that we give out naloxone to people who are regularly using opioids? And so for that reason, we've produced a situation where there's been a lot of lost lives that didn't need to be lost.
Well, you talked about the war on drugs. Nearly 50 years later, there's strong evidence that criminalizing and incarcerating people hasn't worked. But harm reduction was not something the policymakers even wanted to hear about, much less talk about. Why is that, given the mounting evidence that punitive measures were just not working?
Yeah, I interviewed President Reagan's, the director of the National Institute on Drug Abuse under President Reagan, and he recounted what a dirty word harm reduction was understood to be in and by that administration. And I think that in fact, in the federal policy apparatus, you weren't allowed to use the term harm reduction. And so very gradually now, if I went to interview someone like I interviewed before, everyone would say they're harm reductionists because now people understand the need. They understand that people are going to probably have 9 overdoses before the one that kills them, the 10th. Right. And so they understand that there is room and time for intervention. And so there's much more currency for harm reduction, and there's much more time for harm reduction measures to take root in drug using practice. And so I think that harm reduction has really changed over the time that I've been looking. I call this is naloxone, the nasal kind of naloxone. I call it a technology of solidarity in my book because I'm trying to talk about the way in which harm reduction activists came together, realized that they could help themselves, could help their community, and began to do it, often with very little help from federal, state, and local governments. However, in my county, in 2012, the sheriff's department started carrying naloxone, and they were one of the first in the whole country. Now, 2012, you have to understand, to a historian, 2012 is like yesterday, right? It is not very long ago, in other words, that there began to be the realization among state, federal, and local governments and public health educators that we needed to get naloxone out to people.
Well, as you say, we've come a long way when it comes to harm reduction, and there is greater access, but is there a much greater need to expand that access and education on how to use naloxone?
Yes, as it turns out, so in the early days of harm reduction activism, and I looked at harm reduction activism in the UK as well. Scotland had a very, and still has a difficult time with opioid overdose. Many families are touched by opioid overdose there as well as here. And in the early days, the trainings took 4 hours. Now it does not take, it takes 4 minutes to show somebody how to use this. It is not a difficult training. In the early days, naloxone was had to be administered with a needle, subcutaneously or intravenously. But really the subcutaneous route is just fine, the intramuscular route. But since that time, these little intranasal administrations are very, very easy, right? This is not a difficult thing to do at all. And my guess is that there will be other, even more convenient routes of administration coming around the pike. The problem is that naloxone has gotten more expensive.
We can't neglect the fact that there are people who legitimately need opioid drugs, some forced to go to the streets because of the crackdown on prescriptions. So how do we move forward with pain management and these drugs?
Yeah, I think this is a really compelling question to me, because pain is real, it is felt widely, and we certainly need to make sure that pain is something that people understand how to manage and control. My fear when there began to be clamping down and constriction on opioid prescriptions, my fear was what happens always with the war on drugs is if you clamp down in one area, it's like a balloon, one of those balloon animals. There will be expansion in another area if you twist part of that animal. And so I think that we have a situation where people need to learn alternative methods of managing pain. Opioids, quite honestly, should be a last resort. They are in almost every other country. We loosened up on opioid prescriptions in the 1990s in the US to a far greater degree than we should have. And so now clamping down could cause exactly what you said. If people can't get something on the legal market, they will seek the illegal market. And right now, even in the midst of pandemic, the illegal market can be quite convenient. Since the 1920s, there's been a serious attempt by scientists to invent an opioid, to manipulate the opioid molecules to try to get a drug that would have all the benefits and none of the risks of opioids. This has brought us OxyContin, right? This has brought us many molecules that don't do what we were hoping for them to do. This is unintended consequences, is what we're seeing play out. And so we have to think about other ways of handling pain. And I think that there's been much more innovation lately in that sector in terms of non-opioid methods for managing pain. But no, I don't think opioids will go away. They can't go away. They are necessary. And so our question is always going to be, how are we going to live with them? And how are we going to stop so many people dying of them?
Well, as you say, when you clamp down in one area, it balloons in another area. Is decriminalization at least part of the answer? Can it ultimately lead to increased support services and reduce deaths?
Yes, I certainly hope so. I'm watching Oregon, which is beginning to remind me of Portugal, very closely. I think that the policy experiments that we're beginning to see are very helpful. I think it's a long time coming. So, decriminalization is really a move towards a different form of regulation, right? So sometimes when people hear terms like legalization or decriminalization, they think of it as, oh, that's going to be a free for all. That's going to be a nightmare. It's going to increase crime. But no, I mean, that's not what it's about. Because if you think about decriminalization as a way of simply moving more drugs that have formerly been illegal towards legal regulation, that's what we're doing. And so that's what we're beginning to see, is a kind of really interesting shift accompanied by all of these people who have now been informed by harm reduction. And so as harm reduction has become in a sense, respectable, moving from a kind of activist stance to more an advocacy and support stance, and more incorporated into social services. I think we're seeing a really interesting merging of harm reduction with regulation that could actually save people's lives. It is an actual move towards a public health orientation towards drugs instead of a war on drugs. And I think that is something that I don't know that I would have predicted that 10 years ago, even 5 years ago. I don't know whether I would have predicted that we would move towards a more sensible drug policy. But I think that the opioid epidemic has so pressured so many people, so many lives. We've lost far too many people. And I think that that has made people realize this path that we've been treading is the wrong way to go. And so we need to find other routes, and decriminalization is another route.
Well, hopefully the lessons learned from this crisis will prevent a repeat in the future. And to really know where you're going, you need to know where you've been. So, Dr. Campbell, we thank you so much for joining us on NewsPoint 360 with the historic perspective of the opioid crisis.
Thank you very much.